So how many of you, most of you are now, what, 6 weeks into vascular surgery training? Of the vascular surgery trainees, how many of you have seen one open aortic aneurysm repair? Oh, that's good. All right, how many of you have actually participated as the first assistant? Hands up, all the way up, let me see. Actually, that's not bad. How many of you have seen 3? All righty. How many of you have seen or participated in 10 endovascular repairs? All right, well, that's not bad. Hope springeth eternal. My job here is to talk a little bit about endovascular options, and this is a remarkably rapidly changing paradigm that we're going to look at here. So when it started, a little bit of history. Amy, you know who developed endovascular aneurysm repair? Juan Perotti. Juan Perotti was a surgeon, worked out of Buenos Aires, worked in a remarkably small little hospital, and he took 2 concepts. He took a Dacron graft. Who invented Dacron grafts? Invent is not quite the right word. Who developed the Dacron graft? Can't hear. DeBakey. So DeBakey was by complete serendipity. He was looking for a graft material. He went to a department store downtown here called Foley's, which no longer exists, and he was looking for, he wasn't looking for Dacron, and the stuff he was looking for, they said, I'm sorry, Dr. Bakey, we were out of it. But we got this new stuff called Dacron, and he looked at it and said, well, that might do. So he took it home, and the story, of course, is he sewed it into a tube in his wife's sewing machine, got it sterilized, and implanted it the next day. Somebody said, did you get permission from the IRB? And he said, I did. I was the IRB. So things are a little bit more difficult, but basically what Juan Perotti did was to take the concept basically of Dacron, and he coupled it up with a Palmas stent. Who's Palmas? Maybe you know who Palmas is? Pardon? Another Argentinian guy. But where did he work? He was working in San Antonio, actually. And so that's where he was from originally, but he was really a San Antonio radiologist. First time I heard about the idea of putting a piece of chicken wire inside a blood vessel, I thought the guy was out of his mind, and it would never work. Well, there's a few dollars involved in that mistake. And so what he did was he took a Palmas stent, packaged it in Dacron, sewed it on a Dacron, stuffed it inside the sheath, and he developed this concept for treating patients who were too high risk for open aortic aneurysm repair. He never patented it. He never made a dime out of the concept. And so that was the guy who heralded the entire development basically of endovascular repair. And when these things were first being approved, this is kind of what we were looking for. The ideal was that you had about a 15 millimeter, 20 millimeter infrarenal aortic neck. Now that's all fundamentally altered. Some of the infrarenal devices are approved for down to 10 millimeter. Even with that, now we're looking basically at branched and fenestrated grafts. So this is a very rapidly changing paradigm in terms of who we can manage. And the challenge, of course, for us is to how do we actually maintain your open aortic skills, and Dr. Pearl is going to tell you how to go ahead and do that. Now, one of the things, if you're interested in, is we're going to run an open aortic course here in October 5th, which will be cadavers and models, because, you know, I think as a society we're really concerned. What we don't want you to do when you leave fellowship is to look at endo option 1, endo option 2, endo option 3, because you're afraid of the aorta. And, you know, that's one of the reasons to try and get you comfortable with a lot of this stuff. So look at this and forget about it, because it's all basically changed, and it will continue to change based as we go forward. The bottom line is, when I look at these patients and evaluate them, it's all about the proximal seal zone. By and large, you got to seal proximally, you got to seal distally. It used to be there were no branches we could put in, but even that basically is all changed at the moment. But the fundamentals are that you got to be able to seal it above and seal it below the aneurysm. And once you look at that, you can usually figure out how you're going to join these dots. Now, the indications for treating with an endovascular approach, in theory, has not changed from doing an open approach. In practice, that's probably a little disingenuous. I think there are clearly patients who are too high risk for open aortic surgery that would move into the endovascular group. And we kind of look at these patients, you know, if they're relatively young and they got a 4.5 to 5 centimeter aneurysm, they're going to get that aneurysm fixed. The average rate growth of an aneurysm is about 4 millimeters per year. Now, it's not linear. It's often staccato. But by and large, if you're a 45 or 50-year-old guy with an aneurysm that's 4.5 to 5 centimeters, you're probably going to get that aneurysm fixed. And it's a big debate in vascular surgery circles whether you're better going early or going late and waiting to see what happens with these patients. So the key anatomic elements, the things that we look at, now let's just talk about infrarenal aneurysm repair for the present time. You'll hear a little bit about thoracics later, is again that infrarenal aortic neck. Now once again, these diameters have all completely changed and morphed continuously as device companies come out with bigger and bigger devices. But the things that you're really looking at is the diameter. Some companies use internal to internal diameters, others use outer wall to outer wall diameters. You got to know which company and how they recommend their device sizes based upon what their measurements, and there's no consistency in terms of how they're going to do that. Things that make these repairs challenging are as the thrombus in the neck of the aortic wall. And we used to say that if it was more than 30 degrees circumference of thrombus, more than 3 millimeters, probably not a good idea. Again, all gone. We kind of look at these things and we're much more willing to tolerate 1 or 2 millimeter circumferential thrombus, and we would still place an endograft in these patients. We worry about it a little bit more, but nevertheless, the guidelines that were out there are all fundamentally changing. Severe aortic calcification, also we look at it, but certainly wouldn't rule the patient out. If there are irregularities in calcium, a lot of this information is being validated in percutaneous valves. This irregularity in wall calcification can affect the seal zone proximally. And so if they're kind of stalagmites and stalactites, that may be a patient that we're not going to actually put an endograft in. And finally, what you hear a lot about is tapering of the aortic wall. And these things are important, whether they taper, the so-called taper or reverse taper, can affect basically the ability of these devices to seat and the ability for them to actually stay in place. And probably the biggest issue that we actually have is angulation of the aortic neck. And many of these devices in their IFUs are contraindicated if there's more than 60-degree angulation because it's very difficult to place them accurately. But even then, there are some of the new devices, for example, the Lombard device is indicated, and they designed a graft specifically that try and seats better in highly angulated necks. Now, it's not to say that you see an angulated neck, you would automatically want to go to the Lombard device. That's probably not the case. Most people would still use the devices that they're comfortable with, even in angulation, rather than switch over to a different kind of device. So this is what it used to be. You almost never see an aneurysm that kind of looks like that anymore. But at least it serves the focus of what you're going to look at. And this is a publication from Harry Schanzer, which looked to, these were the original guidelines. How many of us are actually conforming with that? And the overwhelming majority of aneurysms are now basically off-label in terms of these original indications that are being reported out there. But there's a price to pay that if we use the devices off-label from the devices manufacturers, then you tend to find that there's a higher failure rate long-term. So bear that in mind. It certainly doesn't stop us doing it. Graft selection. Yeah, I would think that it's good to have your hands on 2 or 3 of these grafts. Most people have a workhorse graft that they tend to get comfortable with and they use. But there are certain situations where other grafts, for example, work a little bit better. For example, suprarenal fixation is something to think about if you have a short infrarenal neck. Once again, even that kind of practice is changing towards thinking now about putting in basically fenestrated grafts or branches into those renal arteries. But by and large, my advice would be find 1 or 2 grafts, learn to use them. Don't basically have 5 or 6 grafts that are sitting on the shelf that you really are not comfortable with and you don't really know how to use that. The reps who come with these grafts are often highly experienced. You may do, in a busy practice, you may do 30, 40, 50 of these a year. They're seeing hundreds of these a year. And so they often can keep you out of trouble. And I think it's important to actually listen to them as they talk through the troubleshooting of these cases. So most of the success is determined by accurate and careful preoperative planning. And each different manufacturer is going to have a worksheet. In practice, you're going to look at these and you're going to work with that rep basically and how you're going to actually size it. And there are different issues that can actually happen. If you get oversizing of a balloon or oversizing a graft, and a bad day is when you dilate up something and you get a ruptured proximal neck. And it may present acutely. I've never actually had an acute rupture. Anybody in here had dealt with an acute rupture intraoperatively from dilating the neck? What'd you do with it, Jason?
Put a cuff higher up. We had arm access, so I was going to snorkel a kidney.
so you covered both renals to save the patient. And the reason that it happened, do you think?
It was over-aggressive dilation of the neck, so we moved towards, now we have a saying, when we balloon the neck, it's all one-handed. For a while, we were really molding the two hands. I mean, I haven't tested how much PSI we get from two-handed versus one-handed. So I think it was purely, it was a little calcified ring around the neck, and I think it was an error in balloon.
Yeah, so typically neck calcification is one of those high-risk areas when you dilate this. Typically, you've dilated it, you see a type 1 endoleak, you go back in, you do a little bit more aggressive, still leaking, you move the balloon up so it's not all within the fabric, and sometimes you see something like that, and that changes your day in the operating room basically fairly dramatically. And as I say, the ones that I've seen or heard about have usually happened immediately, but occasionally it comes back basically and you see these later. And having to convert these intraoperatively, of course, is not really a pleasant thing to actually be doing. So preoperative anatomic assessment is basically going to be based upon the aortic neck, the length, the diameter, the angulation, and the presence of confounding factors that will result in compromise of the seal zone, and that is thrombus or calcification. And then at the bottom end is iliac artery anatomy. Now, the most challenging complications that you get, the more common ones that you get, are iliac artery access rupture problems. And so you can very frequently have pretty good anatomy proximally, but when you've got sub 6 millimeter diameter arteries in the groin, that may be a situation we would think about using one of the trivascular grafts, which are much smaller delivery systems. But iliac artery anatomy, size, diameter, calcification, and tortuosity. And the dreaded combinations when you get all three of these things happening at the same time. The arteries are small, they're calcified and non-compliant, and they're tortuous. And often you're going to be able to get a sheath up there. It's pretty uncommon to rupture these arteries in the way, and you can usually get that sheath up. But the problem is when you actually take it out, that's tends to be when you avulse the artery. And so it's very important when you're putting these things in that you have some sense of whether or not something's happened to that iliac artery. You can go ahead and put that endograft in, but you've got to be prepared to salvage this on the way back out. And most of the time you can actually salvage it. The problems arise, is if you're not suspecting, you pull the sheath out, and those patients will go from being stable to being exsanguinating really very rapidly within a matter of a couple of minutes. And so advise the anesthesiologist that you're worried about the iliac artery, and it's a so-called puff and pull technique. You're going to pull it back and you're going to be puffing it, and when you see extravasation, that's the time usually a Viabond or limb extension that you're going to put in. And that usually seals it, but not always. Every now and again you will avulse right at the takeoff of the internal iliac artery, and so when you reline it from the end of your sheath and you inject dye, it goes straight up the Viabond into the limb. Doesn't mean to say the internal iliac is not kind of hanging in the breeze in the pelvis. So if you have ongoing loss of blood or hypotension, you need to think about that, and you still may have to open it into the retroperitoneum. So we don't need to go through this. Again, some of the CT scan, almost exclusively using the CT scans. And we occasionally use MR scan for a preoperative evaluation, but the resolution is just not quite the same as it does with the CT scan. And so CT scan is the basis really for doing it. I'm going to ignore you middle because we're kind of, not because I'm one of the moderators, but because we're running ahead of schedule. And I'll fill up the time. And so, Greg, you got 50 minutes, or do you need more time? No, it's fine. Okay. So CT, thin cut CT is the way to go. And so, particularly if you're going in these trials, usually it's down to 1 or 2 millimeter cuts is what you actually want. If a patient comes back actually with an endoleak, then we're actually trying to customize the protocol so you actually get almost like less than 0.5 millimeter slices down through the area of the aneurysm. So you don't really need thin cuts, through the chest all the way down through the abdomen. What we're really interested in is what is going on inside the aneurysm itself, and for who knows what reason, you get the same slices all the way down through it, and you really don't need that. And the advantage, of course, basically, is you can look at this in multiplanar reconstruction. And one of the things you really should learn to use is these multiplanar reconstruction windows and work with that, because that's the way a lot of these devices basically are evaluated, particularly for trials, and gives you a lot of information about what is going on inside that aneurysm. And so pre-planning and understanding this is part of the key before you even walk into a control room. And so for us, our workflow, because these scans used to be stick them up on the screen, look at them, look at the patient, figure out what you're going to do. Our workflow now is that patient is put on the table in the operating room. We do DynaCT, fluoro CT, and then we'll give them no dye, and then we'll do CT to CT fusion. And so we'll use the dye from previously, overlay it on top of the patient. And these logarithms that we've got will automatically pull out the origins of the renals, the bifurcation, take off the internal iliac, and overlay that on the patient. So when we put our foot in the foot pedal, for the first time, there's 2 little circles for the renals, 2 little circles for the internal iliac, and it minimizes the amount of dye, the amount of radiation. And we're not sufficiently confident that we'll just go ahead and put an endograft in based upon that, but you can still just puff the dye in to confirm what's going on. So CT scans in the past used to be something that you looked at and then you went and did the procedure. This is now our guidance system really intraoperatively, and so being able to import these scans and actually overlay them, is very important. And this is kind of what I mean by these multiplanar reconstructions. So you can look at the takeoff angles, you can look basically at the diameters of these vessels, and it's very useful to actually use this technique basically intraoperative or preoperatively. All the different device companies have got their own size, and this is pretty straightforward. Now when you start getting into the fenestrated world, it's pretty complex in making all of these measurements. So once you get into the procedure room, again, if you're not doing a 3D overlay, typically, of course, it starts with doing an angiogram. And the angiograms are usually done with a pigtail marker catheter. That's what you're looking at here. These are 1 centimeter markers that you can lay in there, and that is used to measure a center line. The problem is that there's all sorts of problems, with measuring a center line like this. There's no guarantee the graft is going to lay in that angle, and it tends to take that shortest curve you can see right across the neck. But it's as good as you get if you're not actually going to use these kind of fused images to try and calculate what the length is. So what are you really doing an angiogram for? You're trying to lay out what you really are looking at is the renals, the neck, and this neck is particularly horrible, quite honestly. You're going to use that really to guide the implantation of the stent graft. Most of that should have been done beforehand. We've talked a little bit about using the CT scan basically for pre-planning and what you're actually going to be looking for when you're going ahead and doing that. Talked a little bit about sizing. When you see an external iliac that's that size with that heavy calcification, then that's going to be a challenge really to get anything that goes up that side. And so if this is one of those situations where you look at it and you think about it and you look at it again, you think about it and you think maybe I'll get away with this, it's probably the situation that you don't want to be doing this. And that's the easiest thing to do is for us, we would probably just go ahead and do a retroperitoneal access. And so, 10 millimeter Dacron graft onto the bifurcation of the common iliac and the external iliac. There are other techniques that are described, like laying a Viabon up inside that and then just dilating the hell out of it. I'm sure Solopath is, so the Viabon basically is essentially you disrupt that artery, but it gives you a conduit. What Dr. Silva is talking about, which is very useful actually, is this thing called the Solopath, and the Solopath, what the Solopath is a dilatable sheath. Now, interesting, this is like deja vu all over again, because for those of us who are old enough to remember using the original EVT device, that's exactly what you put in there. It was one of the scariest damn things that you ever did. That device was so complicated, you lay awake the nights before. You had the most inexperienced group of people doing one of the more advanced things that had been developed with the most complicated device ever invented. You were just glad to get out of the case the next day. But what they did was they developed a dilatable sheath, a sheath that you put up inside the artery. You advance the dilator. Solopath, you actually dilate it up with an endoflator, and it would stretch up inside the artery. And it actually can be very useful in getting you out of, or getting you access up through a small vessel. I'm not sure I'd use it in this one, but would you? I've never been a fan, basically, of doing endoconduits. Jason, comment? What do you want to tell us about how you do it?
So I think it works great when you already have an occluded internal iliac.
Mm-hmm.
That's a free shot. I take a limb of anybody's device, typically the excluder limb, approximately measures 16. Distally, you can get it down to 10. You get lengths of 100, 120, 140, and you can lay it basically down to the little ligament and blow it up and purposely crack, and then you can get any device up there.
Okay. Percutaneous?
No.
Cut down?
I'm going to do that, but I'm going to cut down so that I can flush well,
yep.
It's likely to breathe, and just have better control of the artery.
All right. 10 Viabon. What'd you do with the end of it? Okay. All right, so size and access, that's one of the challenges to think about, and think about alternate approaches. Increasingly, these devices have been put in percutaneously, and so a couple of different techniques really described from that. We use ProGlide, actually, which kind of lay into these ProGlides right at the start of the case, and I'd say that it works most of the time. Probably 70–80%. We probably break one in every case and probably have a success rate in the order of about 70–80%. So the majority of times you can get away with it. If you identify that it's not working before you lose the guide wire, then it's relatively easy. If you lose the guide wire access and it's not working, then it is one of those clusters and somebody holding their finger on the groin where you actually cut down, you know, around it to try and get control of it. But clearly it will continue to get better basically in the future. And that's the ProGlide in the bottom left-hand corner. Carlos, who works with us, uses basically the pre-close technique and swears by it. So I'm going to stop at that point in time. What time is it we got? Next guy coming up? It's Greg.
50.
All right, Greg. Thank you. We'll let you talk about open aortic repair. Thank you. Thank you.